I'm so happy to be here with you all. I am with Precision Analytical, makers of the Dutch test. And today we're going to be looking at and specifically talking about the Dutch cycle map. I am a naturopathic doctor and I'm a clinical educator with Dutch. We've already gone through this disclaimer, so I'm not going to spend any time there. So, our learning objectives for the day are to review the phases of the menstrual cycle, and then we're going to look at how to use a Dutch cycle map to monitor a menstrual cycle. We'll also get a chance to look at some case examples of both normal and abnormal cycles. We're going to have a very quick short review of some therapeutics that might support the cycle, and then we're going to have time for a Q&A at the end. So make sure to pop those in the chat as you have those. All right, so let's dive in and get the basics of the menstrual cycle down. So typically we think about three phases of the menstrual cycle. An average cycle is 28 days, although it can be longer or shorter. Typically like 21 to 35 days is still considered normal. We often see a little bit shorter in younger patients, longer in older patients. But for the purposes of today, we're going to be going with an average cycle most of the time, like talking about 28 days. So in that picture, typically the follicular phase is cycle days 1 through 13. So that early time. The ovulatory phase, ovulation is 1 day around day 14. And then we have a 14-day luteal phase that's about cycle days 15 through 28. To dive in a little bit deeper, so that follicular phase, sometimes we even break that up into two phases. So follicular phase begins with day 1 of the menses, so the first day of bleeding. Typically that lasts from 4 to 7 days. Typically estrogen, progesterone are very low. The next egg is getting ready to mature and release. Estradiol does start to rise around day 7 and reaches a peak around day 14, which is our ovulation day. So we get a strong estradiol surge that signals for LH release, which then in turn triggers ovulation from the ovary. Ovulation will typically happen on average within 24 hours of that LH surge. Following that, after ovulation, we have the luteal phase, which is typically 14 days. The egg's ruptured from the follicle. It leaves behind a corpus luteum, which produces progesterone. During this time period, we also see a slight rise of estradiol along with that progesterone, which helps support the endometrial lining. If no fertilization occurs, then we do see a rapid decline of estradiol and progesterone, which increases prostaglandin levels, that causes uterine contractions, and we see the uterine lining shed, which leads to the menses and the start of a new cycle. So let's talk about the Dutch cycle map then. So what is a Dutch cycle map? So a cycle map is really an assessment looking at a collection of samples over the course of an entire menstrual cycle, typically that full 28 days, so that you get to see each phase of the cycle. And you can see how much fluctuation there can be in those hormones throughout that cycle. So typically when we think about who to test, we're going to think about recommending the test for patients that are having hormonal cycles. So those could be patients with regular cycles, irregular cycles, even sometimes when they're not having a bleed, they may still hormonally be cycling. So for example, a patient with a progestin IUD that might not be having a menses is often still having a hormonal cycle. We can test them. If they've had a hysterectomy, they may no longer be having a menses, but their ovaries are still having those hormonal cycles. Graded perimenopause. And then whenever there's cyclical symptoms, it can be really helpful for tracking those hormonal fluctuations. So thinking about cycle related complaints, things like fertility concerns, heavy menses, migraines that are more like hormonal migraines, spotting, breast tenderness, PMS. So all of those can be great reasons to run a Dutch cycle map. It is not a test that is recommended for everyone. So if they're not having hormonal cycles, we don't necessarily need to capture a multi-day test. So for our younger patients that have never had a menses, as well as for our older patients that have gone through menopause, either because of surgical menopause with the ovaries removed or natural menopause later in life. Additionally, patients that are on an oral contraceptive, those are suppressive and there's no longer usually ovarian hormone production. So we wouldn't necessarily need to look at a cycle map, even though they are having a bleed. And then we wouldn't use it to diagnose menopause, and we wouldn't use it to monitor hormone therapy either. So in these cases, they're all in more of a steady state hormone level. So they're not fluctuating like we see for our cycling patients. So in these cases, a single day collection would be sufficient. So something like a 4 sample collection, which is more of a 24-hour picture, a Dutch complete or a Dutch plus would be helpful. So when we think about when to test and how to test, we do often think about testing in serum for our cycling patients. When we're doing that, we think about two particular times that we're trying to capture. Cycle day 3, when estrogen and progesterone should be very low, is a common day to assess. There's times where we might see high estradiol, and that might be suggestive of low ovarian reserve. Even more often, we're often trying to capture a mid luteal collection. So we'll look at serum on potentially days like cycle days 19 through 21, again, when they're having a 28-day cycle. This is when we expect moderate progesterone or moderate estradiol, highest levels of progesterone. So we get to see the follicle was developed and ovulation occurred. And this is also when we're going to be assessing that estrogen progesterone balance we're often talking about. So you do get those single point in time measurements, or we can look at a cycle map where we get to see again a cycle all throughout. And this is really helpful. So instead of going to a lab, it's an easy collection at home, and you're going to get a lot more information about all of the phases. So, not just those two time periods, but potentially follicular, ovulatory, luteal. And it takes a little guesswork out, especially when there's irregular cycles. So, why might we test? So, really, we're thinking about looking at all of the phases and wanting to see the picture of what's happening throughout that cycle and then that timing relative to the patient complaints. We're also looking at trends over time, like so throughout that time period versus that single day assessment. So in this instance, we have two patients, both having 34-day cycles. If we collected at that mid luteal time period, so about 5 to 7 days before their menses, which for them is day 27, I've circled it here for you, they would look exactly the same if we were to be looking at that in serum. Versus here on the cycle map, you can see quite different that they're both anovulatory cycles. We see very low progesterone, but that patient on the right is having an estrogen cycle and very likely is having a lot more estrogen dominant symptoms that might not have been explained by that mid luteal collection where estrogen actually is fairly low. And then our treatment approach to each of these patients is likely to be quite different. So you can see how having that additional information of the earlier time in the cycle could be really helpful. So let's talk about using a Dutch cycle map. On the patient end, we do include instructions for 3 different collections. So there's options for a normal, which is a cycle that's less than 34 days, or for a long cycle for a cycle that's longer than 34 days, as well as that no cycle. So, again, an IUD patient, hysterectomy, ablation. The patient is given a collection schedule, typically starting on day 7, collecting every other day to every day. And then the lab uses a sampling of 9 different days so that we can map out each phase of the cycle and get to see that estrogen progesterone output. The patients do collect at the very end once their next menses and cycle has started, typically around the next cycle, day 3 to 5. They do a 4 sample collection day. This provides the early follicular data, as well as if it's paired with additional Dutch testing, it's where we would get cortisol information, which is why it's that 4 point collection at that point in time. So, again, just to review that normal menstrual cycle before we dive into looking at some cycle maps. And I've brought lots of examples because I think that's where it's really fun to get to look at what these look like in a lot of different cases. But this is what we'd expect a normal menstrual cycle to look like with that estrogen progesterone. So, again, 4 phases here. So, that follicular phase includes the menses early in the follicular phase, the ovulatory or periovulatory phase, which is really a 1 day, and then that luteal phase. You can see why timing for cycling patients can be so important. But with a cycle map, we get the benefit of seeing everything throughout that cycle. When we're looking at these cycle maps across that X horizontal axis is mapped out the cycle day. Across the Y vertical axis is going to be the hormone measurement. Between those gray dashed lines is our expected range. So that's when we're looking at these cycle maps, that's how to read them. And then before we look at some of these examples, I want to talk about measuring hormones in Europe. So you'll notice on the Dutch test, we use beta pregnol as a surrogate marker of progesterone output. We don't really pee out progesterone. We're peeing out progesterone metabolites. Primarily, beta pregnanediol is our most predominant. And you can see we've mapped out here on that top graph that urinary beta pregnol mapped against serum progesterone throughout the cycle. There's a really strong correlation. And then down on the bottom, we see the same thing with urinary estradiol. Some providers do like to use estrone as an additional surrogate marker for estrogens. So we do include that as well on the Dutch test. But here you'll see that strong correlation between urinary estradiol and serum estradiol. So those track really nicely. This data and those graphs are from published papers that are available to you if you're interested. And then we've talked about estradiol, we've talked about beta pregnol. We are measuring one other thing on the Dutch cycle map, and that's the alpha pregnol, which is another metabolite of progesterone. So beta pregnol is all over medical literature as the strong correlate with progesterone levels. Again, it's the most predominant. But we are also seeing some information coming out about alpha pregnol, particularly around PMDD. And then in addition to that, 5 alpha prenadiol is metabolized by 5 alpha reductase. So this measurement can be an additional look at 5 alpha reductase, which might be relevant to someone like a PCOS patient, because 5 alpha reductase also is metabolizing androgens, may have an effect on mood regulation, can be a sign of insulin insensitivity if you see high 5 alpha reductase activity. So we get alpha pregnol as a marker of progesterone production, but it's also a marker of 5 alpha reductase activity. So again, we're getting even more information than we might get on a serum test. All right, let's dive into case examples where I think things get really interesting. Again, we're going to start off with a really normal cycle. So this is a 28-year-old normal 30-day cycle. So you can see a classic picture here. So cycle day 13, we see her estradiol peak. Cycle day 21 is her beta pregnol peak, so her progesterone peak. So with those, when we have those graphs, they're charted out on the top. There is a table with all the measurements included on the cycle map down below that. You can see there I've circled those peak days. So it was sample 4 or cycle day 14. That was the peak of estrogen. And then it was sample 7, which is highlighted because, again, this will highlight our mid-luteal peak where we might be comparing estrogen to progesterone levels. So here we do get to see that peak progesterone on sample 7, day 21. Some providers do look at a beta pregnanediol estradiol ratio. And so that is also included down in the table below when we're looking at that. All right. We're getting away from normal, although this one is still quite normal, even though it looks a little bit different. So this is a 46-year-old who's no longer having a menses. She's had her uterus removed. Ovaries are intact. Really, she's got fairly normal estrogen and progesterone. But what's happened is the pattern is shift because we were no longer able to know when the start of her cycle was. So what it looks like here is that we actually caught 2 luteal phases. So it looks like the beginning of that cycle map. So those first 10 days or so are the end of a cycle. So if we started with a luteal phase, we then see that early follicular phase when things are low. Around day 21, 22, 23, we get a peak of estrogen. So that's like her ovulatory phase, followed by, again, a rise in progesterone. Later on, day 29 or so, we see that peak progesterone. So we really caught at what looks like a cycle and a half here. And it's interesting to see that she is still cycling quite normally. Looks like her cycles are probably a little bit shorter than that average 28-day cycle, though. In this case, we have a 50-year-old who has regular cycles, but she's complaining about a lot of perimenopausal symptoms. So here you can see first off, like there's some estrogen dominant. So there's a lot more estrogen around compared to when we look at the progesterone. That beta pregnanediol in particular, barely getting into the luteal range towards the end of the cycle. The other interesting thing about this cycle map is that high day 4 estradiol. And a lot of times that can indicate diminished ovarian reserve. So there's some signaling issues, which is very common in perimenopause as we're transitioning into menopause. But you can also see why she's still cycling regularly. She's got all of the elements there. She's got that pre ovulatory estrogen surge. And then she does have a luteal rise of progesterone. She did ovulate. So even though things are winding down, those ovaries are still kicking on their way out for now. All right, here's another really interesting one. So this is a 31-year-old trying to get pregnant. She's taking 100 milligrams of Clomid. She's using that days 2 through 7. So there are some folks that want to see what that luteal phase looks like after they do ovarian stimulation. We don't have expected ranges on those therapies, but what we're getting here is what you would expect to see. So again, she dosed her the Clomid, days 2 through 7. You can see that by day 11, estradiol estrone levels have soared. They're way past their normal ranges. And in fact, that like vertical scale there, that y axis has had to expand and squish down our normal ranges quite a bit. So typically that normal ovulatory range for estradiol tops out around 12. She's almost 4 times that. So she's quite high. Again, that's the effect of her medication. She's recruiting a lot of follicles. It's working. It's doing what it's supposed to. The estrogens then do settle down to pretty normal luteal ranges after ovulation occurs. And then her progesterone soars. So again, we get really nice, big, robust progesterone, high normal, which is again what we typically expect on these fertility meds. Doesn't look like she got pregnant this cycle. We do sometimes see that they do. And what you would expect to see is that estrogen progesterone past that mid luteal peak would continue to rise. They wouldn't have that drop that triggers a menses. All right, here we have again, this is a patient who's not having a menses. This is a 25-year-old. She's got a Mirena, which is a progestin IUD. So she's still cycling. She was having some complaints, and so we took a chance, went ahead and did a no cycle collection. We do, again, there's a little bit of a shift in this pattern. So by day 1, when she first tested, she was already having that pre-ovulatory estrogen surge. So we caught her kind of around ovulation at the very beginning. And then by day 10, she's mid-luteal already. So that ovulation happened more in the beginning of her collection, again, because we weren't quite sure of the timing. So something to know about those progestin IUDs is they're most often exerting a local action on the uterus. They thin the endometrium, they change cervical mucus, which is how they achieve birth control. But that largely leaves the ovaries active. So they're still developing follicles, they're still ovulating, just like for patients that are still having normal menstrual cycles. In this case, this patient, I would guess, is having long cycles because we did capture that cycle. We don't see another. We're maybe starting to see the beginning of a rise of estrogen towards the end. But my guess is if she was cycling, maybe she would be a little bit longer than our typical like 28, 30-day cycle. But we did capture what we wanted to see here. All right, here's another one. This is a 38-year-old who's having constant bleeding. And you can probably see why. Her estrogens are consistently high. There's really not much of a cycle here. We're just getting a lot of estrogen. Progesterone pretty flatlined. There's no ovulation happening. So in the end, after some additional workup, this patient we found was had endometrial hyperplasia. And you can see why. There's a lot of unopposed estrogens there. All right. And then on the other side here, this is another anovulatory picture. We have a 27-year-old with amenorrhea. So we have really no action happening, right? We have low estrogens throughout that cycle. We have low progesterone throughout that cycling. We really wanted to see if there was anything happening, is why we ran the cycle map on her to see were there any blips of estrogen. Are the ovaries trying to do anything? And in her case, they weren't. For this patient, the next step would be some additional workup to find out why she's not cycling. And then moving a little bit away from the cycle map, but I did want to talk about complementary testing. So a lot of times with that cycle map, we get that estrogen progesterone information. But if we add something like a Dutch Complete or a Dutch Plus, you can add to that information and get even more. So if you wanted to know more than just estrogen progesterone levels, Pairing it with a Dutch Plus or Dutch Complete can be excellent. So for instance, you'll get to see like androgens, you'll get to see the adrenals, and you get to see hormone metabolism, which can be both really relevant for both short-term and long-term health. When these are paired, these two tests, we do pull that peak luteal information. So in this case, day 21 is pulled over to that Dutch Plus. So you'll see that estradiol and that progesterone correlate with what we found on the cycle map. So again, for irregular patients, this can also be really helpful. This is actually a 46-year-old with a lot of perimenopausal symptoms. She's a lot like that earlier cycle map that we looked at, who had a hysterectomy and was also 46. So here's an example. Here's looking at some of that additional information. So on the cycle map, we saw the high estrogen. We saw that low normal progesterone. What we didn't get to see that we now get to see for this patient is in her estrogens, we get to see how she detoxifies them. So we get to see phase 1 detox, phase 2 detox. And then again, we get the full androgen picture. So we get androgen levels as well as a measure of 5-alpha reductase. In this case, it might be pretty relevant. She has pretty low normal androgens, which might be important for her symptom picture. So again, this is becoming even more comprehensive than the cycle map alone. And then we get to add on, in addition to that sex hormone information, we get adrenal and organic acid information. So again, the pertinent things for this patient is low normal DHEA, low cortisol. Her diurnal pattern is a little different than we might expect. It's a little high upon waking, and then it drops throughout the day. And I know it's really hard to see, but she also took an insomnia sample, and her cortisol was high at 2 a.m. So we got to see that as well for her. Organic acids for this patient were quite normal. So in pairing a cycle map with additional Dutch testing, we can get a really comprehensive picture and dive deep into what's going on for that patient. All right. And then as we get close to wrapping up here, I did want to leave you with some supports that we would to support the different phases of the cycle, things that we would consider. So here's some nutritional hormonal requirements that are for each of those phases that help keep things running smoothly. Of note, I think, is how many of these are antioxidant and mitochondrial supports. In addition to that, we need normal hormonal activity from the adrenals. We need normal thyroid activity. We need good tissue conversion of T4 to T3. We need those fat-soluble vitamins. We need minerals like zinc, magnesium, selenium, iodine. And you'll see it's all loaded heavy in the follicular phase. There's supports throughout the cycle, but that follicular phase in particular, pretty heavily loaded with the needs and supports. And that's because if we really support that follicular phase, it'll pay us back in the luteal phase, where we get a really nice, strong corpus luteum that's going to produce a lot more progesterone. We're going to get better egg quality, things like that. So just going to leave you with those therapeutics there. And we're going to wrap things up. We have some time for a Q&A now. And I just wanted to say thank you all, and we'll open it up.
Welcome to Rupa Health, the best place to order, manage, and track results from over 30 different lab companies in one single place for free. It's going to take you under 2 minutes to sign up, and you can order any functional medicine lab for your client in under 30 seconds. Let me show you how it's done. So here's our beautiful interface. I'm typing in the name of my client, selecting the lab that I want to order for them, and hitting send. From there, Rupa and their amazing team handle the rest. They email the client, collect payment, and even offer an interest-free 3-month payment plan. We've also built the world's largest library of information about chronic health conditions, the lab tests that can help you find the root cause, and the evidence-based interventions that you can use to help people heal from them. It's called the Rupa Health Magazine. There, we have in-depth articles about almost any health condition you can imagine. And we give you step-by-step protocols that other clinicians have used to help their clients heal and that are verified by evidence-based sources. You should totally check it out, and it'll transform your practice. And we can't wait to see you. So make sure you sign up today at rupahealth.com.